Welcome to the Women's Caucus first webinar of 2020. This webinar, titled Critical Issues in Women's Health, features 3 of our highest abstract award winners from the 2019 APHA annual meeting. The Women's Caucus is committed to providing a forum for the uninhibited discussion of emerging, not often considered, and important issues affecting the lives and health of women globally. I encourage you to learn more about the Women's Caucus by visiting us on our social media sites or visiting our website, where you can also sign up to be a part of our organization. Now I would like to introduce our speakers for today. Our first speaker will be Keisha Ellick. Keisha is a part-time professor in the psychology department at Clayton State University, as well as a PhD candidate in family science at the University of Maryland College Park School of Public Health. She received bachelor's degrees in psychology and sociology from Georgia State University and a master's degree in applied developmental psychology from Clayton State. Her dissertation research explores stress and coping among highly educated women. Other research interests include sexual and reproductive health of Black women and girls, psychosocial development in Black adolescents, parenting stress, co-parenting, and self-efficacy in teen parent families. Our second speaker will be Ava Skolnick. She's a clinical research coordinator at Policy Lab and the Center for Pediatric Clinical Effectiveness at the Children's Hospital of Philadelphia. She has experience in qualitative and quantitative research and policy and advocacy. Currently, she is working on projects aimed at improving adolescent sexual and reproductive health outcomes, both domestically and abroad. And our final speaker for the day will be Kelsey LeBeau. She's a doctoral candidate studying public health with a concentration in social and behavioral sciences at the University of Florida. She holds positions as both a graduate research assistant and teaching assistant. She received her Bachelor's of Health Science and Master's of Public Health from the University of Florida as well. So without further ado, I'd like to begin with our first speaker, Keisha Ellick.
Who had a popular song with the hook, "Started from the bottom, now we're here." This hook indicated a state of arrival, achievement, or success. According to the song lyrics, the goal, the dream had been reached, and all was happy and well in the world. While pondering the title for my research, this song came to me. Black women have historically been on the bottom of a socio-political hierarchy with white women and all groups of men. In the last few decades, however, Black women have seen tremendous growth in regard to education, income, career, wealth, and political power. Black women theoretically started from the bottom, but where exactly are they now? Because all does not appear to be happy, healthy, and well. Advanced education has afforded Black women greater professional opportunities, which they have leveraged to secure leadership positions in education, healthcare, social services, law, and technology. As a predictor of household income and social class status, education is also a social determinant of health. It is thought to play a critical role in well-being and is generally considered a protective factor against negative psychosocial outcomes, especially for women. However, for Black people and Black women in particular, the cost of the social mobility afforded by advanced education results in diminishing returns. The state of Black women's health is a growing public health concern. This concern is reflected in the headlines of pop culture magazines and business annuals, as well as empirical studies among the scientific communities. Data tells us that a primary contributor to the disparities that we see in Black women's health outcomes is the body's physiological response to stress. In short, when we feel threatened, our brain triggers a series of changes designed to prepare and aid the body in protecting itself. Stress hormones are released into the bloodstream, just the reproductive system suppressed, and activity in the temporal lobe of the brain, where the limbic system regulates mood, motivation, and fear, is heightened. Once the threat is eliminated, the body returns to its normal levels of functioning. This biological response is nature's defense system to the threat of physical harm. However, it occurs in response to emotional and other psychological distress as well. Occasional activation of this stress response is not problematic. In fact, this fight or flight reflex can protect individuals from harm. However, continuous activation of this stress response to chronic psychological stressors or threat to our mental well-being can have long-term detrimental consequences on health. Black women are disproportionately affected by a number stress-related health conditions that decrease their quality of life and shorten their lifespans. For example, over 1,700 Black women die each year from breast cancer. That's 5 Black women each day. Compared to white women, Black women are twice as likely to die from cervical cancer, 2.5 more times more likely to die from stomach cancer. Black women are also 1.5 times more likely to have high blood pressure, 60% more likely to be overweight or obese, and have double the rate of diabetes. Black women are 4 times more likely to die from pregnancy-related causes such as embolism and hypertension, and have the highest rates of premature birth and low birth weight babies. And Black women's babies are 2.5 times more likely to die during their first year of life. Middle class and upper middle class Black women suffer the same poor mental and physical health consequences and experience these consequences at the same rates as women who are living in poverty. This suggests that factors such as education that are commonly purported to protect people from negative health outcomes may not hold true for Black women. Race and gender discrimination are significant sources of stress for Black women. It is suggested that advanced education may exacerbate these negative experiences by reproducing and social inequalities that inform them. Black women with advanced education are more likely to have professional careers which expose them to work-related stressors that include overt and covert racial, gender, economic, and political discrimination and oppression. They may also experience social isolation from being the only Black person or only Black woman in their work environments. Stress may also stem from the strain of societal and cultural expectations associated with being Black and being a woman. Social cultural expectations dictate Black women's perceived relationships with family, career, and community. Black women are expected to uplift the community and positively represent the race at all times. Women are also expected to marry heterosexually and to bear and raise children. The concept of hegemonic motherhood supports an intensive mothering strategy where women limit their personal pursuits in order to be readily available for their children at all times. This actually serves as an assessment of their womanhood by others. Culturally speaking, Black women are also expected to work outside the home and contribute financially to the family, while simultaneously and successfully managing their marriages and children. Scholars have begun to challenge these expectations. For example, Barnes explored the experiences of Black women who redefined their relationship with career and chose to devote more time to their families. As she discusses, this strategic mothering is done in an effort to ensure the survival of the Black family in the Black community, but may actually further embed Black women into a sexist and patriarchal system. Conversely, a significant number of middle-class Black women are choosing to remain single and not parent, and the experiences of Black sexually minority women are often underlooked in the studies of Black class. Among Black families, alternative family structures and extended family networks play key roles in family management. However, research on Black middle-class families is limited in its conceptualization of family. Many families in the Black community consist of non-kin relations. They may include the care of elderly parents or disabled family members, and also parents with adult children who are not actively parenting, but whose children still play an intricate role in the family dynamic. This leads to the weathering of Black women's bodies, which is the accelerated aging of human cells. So while Black women may appear to look good on the outside, they are literally aging faster on the inside. This weathering is a direct biological response to stress. The literature suggests that Black women engage in 2 primary reactive responses to stressors. One is identity shifting, also known as code switching, which involves the altering of appearance, speech, or behaviors in order to fit in with a dominant white culture. Black women engage in these behaviors in order to minimize their experiences of discrimination. There is also the internalization of the strong Black woman schema, in which Black women prioritize caregiving, constant displays of strength, and resistance to vulnerability, and the motivation to succeed despite their limited resources. This is actually the result of socialization from previous generations, but Black women embrace this persona in order to avoid judgment for not meeting the perceived cultural expectations of womanhood. This constant state of hypervigilance can result in more experiences of stress and more physiological stress responses. Again, the disparities in poor health outcomes persist across socioeconomic lines, and neither education nor its correlates appear to protect Black women. We do know, however, that coping can mediate the influence of stress and the physiological responses on individual health. So the purposes of my current research was to explore the experiences of highly educated Black women during their prime work, partnering, and reproductive years. This study examines the strategies that highly educated Black women employ to cope with stressors perceived while navigating, negotiating, and performing multiple social roles, identities, and responsibilities in their personal and professional lives. I chose a qualitative approach to answering the research questions because qualitative methods help us to better understand the specific ways in which highly educated Black women perceive and cope with stressors experienced in their daily lives. This approach will help me to better understand the meaning that Black women give to their lived experiences and the processes through which these experiences influence their health outcomes. And as the study is discovery-oriented, I want the theory to be grounded in the data obtained from the narratives of women. Interviewing is my primary instrument of data collection. I approached this study through the theoretical frameworks of Black feminist thought and life course theory. Black women are a diverse population and require an intersectional approach in examining their various social roles and identities. This framework provides a lens for examining Black women and the choices they make for themselves and their families, and how their choices change in various contexts. Black feminism gives voice to the lived experiences of Black women, as well as the knowledge that is gained from their intersecting impressions of race, class, and gender. Through Black feminist thought, the voices of Black women are centered and are the criteria for meaning making of their experiences. Life course theory complements Black feminist thought by examining the cumulative impact of intersecting impressions of race, class, and gender over the lifespan. Through human agency, Black women give meaning to the changing social structural context through self-reflection and their behaviors as they work to be recognized for their talents and skill. The life course concept of linked lives also applies. Black women's lives are shaped by their relationships and obligations to others. These relationships are bidirectional and influenced by life's transitions. Both frameworks speak to the varying roles that Black women navigate and the ways in which these social roles are negotiated and renegotiated over time. Purposive sampling was conducted to recruit participants from the intended population of highly educated Black women. I utilized a social media campaign in order to recruit participants. The local you see here now was created for use on various social media sites and was designed to attract the attention of my target population. This image is accompanied by the acronym WeBAD, which stands for Women's Experiences as Black, Ambitious, and Degreed. Women who expressed interest in participating were directed to a survey to confirm their eligibility. To be eligible, women must self-identify as Black American or African American, though I'm very specific about my use of the term Black. They must be biologically female, live in a designated recruitment area, have a doctorate level degree in their respective field, and be currently working or actively seeking employment. I'm intentional in my use of the term Black to define and describe the racial cultural group of people of African descent who are born and raised in the United States. The history of marginalization and oppression of US-born Blacks, along with the current inequities that exist for this group, contributes to variations in the experiences of Black Americans, which may be different from people of African descent, other people of African descent. Sample size is difficult to estimate. I do want to capture variation in relationship status, family structure, experiences, and health. And I'm not quite sure that theoretical saturation is my primary goal. I'm more motivated by creating original knowledge through in-depth inquiry and analysis. That said, I do understand that more does not equal better. However, based on the grounded theory approach, I anticipate a sample size of approximately 30 women. One-on-one interviews are conducted or have been conducted in person utilizing a semi-structured interview protocol. This allows an interactional exchange between me and my participants, and it is my hope that our shared race and gender can help set the foundation for trust and dialogue with these women. With consent, interviews are audio recorded for later transcription and analysis. I am taking a grounded theory approach of thematic coding using a triadic coding scheme of open, axial, and selective coding. I will go through the initial round of open line coding, going line by line, looking for significant segments and sensitizing concepts, and then end with a selective coding methods where I generate theoretical or conceptual frameworks based on the information gathered. I did conduct a pilot study in order to help narrow my focus and develop my current research questions. The original interview protocol was designed to capture the ways in which highly educated Black women perceive and reconcile the competing demands of family and community with their professional responsibilities. My pilot study consisted of 7 interviews conducted with women in Metro DC and Metro Atlanta, and those interviews range from 58 to 91 minutes. Some emerging themes from my data were that women felt that they were always on or in a constant state of hypervigilance, particularly in the workplace. They reported constantly fighting to be heard and never being sure when it was safe to speak up for themselves. They also reported feeling tired of being the strong one in their family and community networks. I learned a lot from this pilot study based on the conversations I had with other Black women during our interviews and reflective analysis of my own experiences as a Black woman with an advanced degree. I realized that Black women can easily identify many of the sources of stress in their professional and personal lives. However, I realized that what I had to have a better understanding of was how these highly educated Black women attempted to cope with this stress. Therefore, my research questions were developed to focus on coping processes. I am currently in the midst of full data collection. So far, I've collected 16 of my magic number of 30 interviews and have just begun my first round of open coding on the data that I have thus far. I have already begun to recognize some recurring themes in the women's narratives. I've also found that some of the stressors that these women have or are experiencing are very salient, and the conversations often lead to a physical display and release of emotion. As part of my protocol, I have inducted the assistance of a Black female psychotherapist who, upon request, will offer free counseling and debriefing sessions to my participants. And this is where I am right now. Again, I am in the midst of data collection for my full study. The data collection is scheduled to be completed by the end of this month, and then we begin analysis. And I'm excited to present my results in the next few months.
Awesome. Thank you so much, Keisha. And I forgot to mention, Keisha earned our highest scoring honorable mention student abstract for the 2019 APHA annual meeting for the Women's Caucus presentation. So next we're going to have our speaker, Ava Skolnick.
Hi everyone, can you hear me okay? So thanks so much, Michelle. Thanks so much, Michelle, for having me and for organizing this panel, and thank you for presenting that. It's so interesting. So like Michelle said, I'm Ava Skolnick. I work at Policy Lab at the Children's Hospital of Philadelphia, and today I'm going to be talking about a reproductive justice framework to improve care for young women with IUDs. And I have no disclosures to report today. And so a little bit of background on IUDs. So they are an intrauterine device, and intrauterine devices, commonly known as IUDs, are one of the most effective contraceptive options, and the effectiveness is about 99% for preventing pregnancy. And there's low IUD utilization among adolescent and young adult women compared to adults, and also if and when young women do decide to initiate an IUD, there's also higher discontinuation rates compared to adults. And so long-acting reversible contraceptives, commonly known as LARCs, include IUDs and Nexplanons. And so IUDs are considered the first-line contraceptive choices for adolescents by many medical and public health organizations. And this is from a recommendation that came out in about 2014. However, there's a tension that exists between the public health model versus the medical model. And so this LARC-first approach is increasingly critiqued for creating tension between achieving public health goals and individual priorities in reproductive justice. And so for the public health model, we can think about it as wanting to decrease the overall rates of teen pregnancy nationwide, and using long-acting reversible contraceptives, LARCs, can help us achieve this goal because we know that they're the most effective method of birth control. However, in the medical model, we really have to consider the individual patient's needs, priorities, and what fits best for their lifestyle, and that might not be a LARC. And so if we're using this LARC-first approach, we really have to balance both the public health model and the medical model in doing so. And so I'm going to briefly talk about what is reproductive justice and encourage everyone to do more reading about reproductive justice and dive deeper, as I won't be able to cover what it is today. But reproductive justice was started by a group of women of color, and I'm going to make the distinction between reproductive health, reproductive rights, and reproductive justice. And so we can think about reproductive health as focused on service delivery. And so this is for young women who have access to clinic and are able to get birth control if they want it. Reproductive rights is really focused on legal issues, and so we can think of this as adolescents who in many states are able to access free confidential contraceptive services and are able to consent for those services by themselves. And reproductive justice encompasses both reproductive health and reproductive rights, and more broadly is focused on bodily autonomy, the choice to have children or not have children, and to parent children in safe communities. And this photo on our right, very clearly demonstrates what that could mean for young parents by an artist named Megan Smith. And so it says, "You deserve to be treated with dignity, kindness, and respect, no matter at what age you choose to parent. Justice for young parents is reproductive justice." And so reproductive justice, IUDs, and adolescents are uniquely positioned due to their developmental stage. And so adolescents' brains and decision-making skills are still evolving. And so adolescents have varying needs to understand reproductive care and their reproductive rights and healthcare decision-making and healthcare navigation as a whole. And so we really need to understand where adolescents are developmentally in order to understand how they're choosing their contraceptives. And so by applying a reproductive justice lens to understanding IUD decision-making among adolescents and young adults, we can really inform provider counseling strategies and prevent inadvertent reproductive coercion and be able to tailor the counseling as appropriate for each adolescent. And so the objective of the current study is to explore the perspectives of adolescent and young adult women regarding what reproductive justice looks like in their decision to initiate an IUD. And so the methods of our study is that this was a secondary data analysis. And so the parent study was to understand factors influencing IUD initiation and continuation among young women. And it was for young women ages 14 to 22 years old who had a hormonal IUD placed in the prior 30 days. And the setting was a large urban clinic on the East Coast. And visits were 30 days after the IUD placement, 6 months, and 12 months, as it was a longitudinal study. And the study's been approved by the IRB as well. And so the current study that we're going to focus on today is only using baseline data, so that data that was collected 30 days after IUD initiation. And in that data, we have socio-demographic questionnaires and also conducted semi-structured interviews either by phone or in person with the young women and assessed factors that influence method initiation that is known from the literature. And so here you can see the baseline interview domains that we use, the factors that influence method initiation. And these include attitudes towards pregnancy and individuals' method preferences. And so we can think of that as dosing or how frequently you have to go to the doctor, social references, so what friends and family recommend the young person's birth control method to be, their information needs, so what the young person is asking of the doctor and what the young person is seeking out information on their own, their motivations for being on an IUD, such as whether they don't want to be pregnant or whether they want to lessen their bleeding and cramping, the environmental factors such as insurance or ability to access the clinic, and then also we covered their clinical care and management services during their insertion procedure and prior counseling as well. And so the analysis we conducted was 2 coders who deductively coded using this framework that I just mentioned. And then 2 coders, myself included, refined the codebook, and our principal investigator served as the arbitrator for that. We reviewed query reports to identify the presence of reproductive justice concepts within this framework, and we refined the codebook to include reproductive justice domains. Then we also purposely sampled transcripts across age, race, insurance type, and contraceptive history categories because we know that people's experiences with reproductive health care varies across all of those different domains, and we really wanted to take an intersectional approach to data analysis. And we coded these transcripts until thematic saturation was reached, which was at about 20 transcripts. Then we reread the transcripts in their entirety to understand how reproductive justice concepts were situated among other influences on IUD initiation. And here you can see the participant demographics that we were sampling from. And so we had an even split between younger and older adolescents. About 70% of the young women were Black and 25% were white, and an even split between public and private insurance as well. And then we also asked young women about their prior contraceptive history use, and about 78% of them have previously used a prescribed contraceptive. And so we looked across all women to find themes that came out amongst them and really tried to fit young women into different categories. And what we found was that there was not a single story amongst the young women, that each young woman had different themes that were coming up throughout. And while the majority of them had similar themes, each story was very different. And so we really wanted to take that into account today in presenting our results. And so I'm going to go through some case examples that highlight each of these themes. And so these are the major seven themes that came out of the results, such as autonomy, so the ability to make decisions for oneself; method convenience, which was the ability to have one insertion procedure, and what many young women would say they would be able to forget about their IUD; the motherhood bar, which we can describe as kind of a social norm of what needs to be achieved in order to be thought of as a good mother. So things such as needing to finish school before becoming a mother, having financial goals, being in a healthy, happy relationships, and things of that sort. Also contextual influences, so the environment around you and how that's influencing IUD initiation. The medical effects of the IUD, such as the ability for the IUD to alleviate a lot of menstrual problems. The individual's attitudes towards pregnancy, so how they felt about being pregnant one day. And what we found is that while we commonly think of attitudes towards pregnancy as either someone wants to get pregnant or does not, and we think of that as a binary, what we found among the young women is that attitudes towards pregnancy is really happening on a spectrum. And so we found that some women are definitive that they don't want to get pregnant. Some women want to get pregnant one day and not now, but would be willing to accept it if they were to get pregnant today when asked about it. And we can go into more detail about that later. And then lastly, influencing their IUD initiation, whether the social influences, so influences from friends and mothers and parents as well. And so the first participant that I'm going to go over today is an 18-year-old Black woman who is publicly insured and has previously used contraceptives. And so when talking about her aspects of autonomy, she stated that she liked the fact that the doctor told me all of my options. They didn't pressure me to get it. And you can see in this quote that there was influence from the doctor. However, she felt like she was autonomous in her decision to initiate the IUD. For this young woman's attitudes towards pregnancy, when asked how she would feel if she were to get pregnant now, she stated, "I feel like I would be upset because it would definitely have an impact on school and the course of my life. I would have to get a job. I couldn't do the same things I do now." Themes of method convenience also came up for her. So when asked why she really chose the IUD, she stated that it was one less thing for her to think about. And then additionally, contextual influences came up for this participant. So she stated that she knows people who have kids. It's a mistake that happens. I feel sad because I know they have a lot of potential to do really great things. They have to put their life on hold because they have a kid. So we can see that multiple themes came up for this participant in varying degrees. And so themes of autonomy, attitudes towards pregnancy, method convenience, and contextual influences all were deciding factors in when this woman was considering to initiate an IUD. The next participant example that I want to go over is a young woman who was 17 years old, Black, privately insured, and previously had used contraceptives. And so again, themes of autonomy came up for this participant, but in a different way. So this participant, when asked about their counseling, said, "The doctor said condoms and the pills were not on the same level as the next one on the IUD. It was just more cramps and pain and periods and stuff like that. And so she just said to get on the IUD." And so this participant, while she decided to get an IUD, feels like the provider had greater influence on her decision to get an IUD. And while we don't know what happened in that situation, we can see that the way that this participant is recalling the interaction seems like the provider really was the decision maker in this instance instead of more of a shared decision maker. And maybe this participant had less autonomy than they would have otherwise wanted to. When asked about how this participant would feel about getting pregnant today, her attitudes towards pregnancy were as follows. She said, "I wouldn't mind. I'm not for abortions or anything like that, so I wouldn't mind. I know that I have a good support system, so it wouldn't really matter because I'd have my mom and her husband and my boyfriend and his mom. They all communicate, so I know it wouldn't be a problem." And so we can see that while she's on the most effective form of birth control, she also would be okay if she were to get pregnant due to her support system and saying that she doesn't mind as well. The medical effects and the menstrual benefits of being on the IUD also influenced her. So when the interviewer asked what things make you want to continue to use the IUD, the participant responded, the effect that it has on my menstrual periods. This participant was also heavily influenced by her boyfriend's desire to be a parent and also the motherhood bar as well. And so this participant stated, my boyfriend's looking forward to being a parent, but at this time in life, we both put it off until I graduate and I get my first 2 degrees. We have a house and a car, and we'll have money to raise our child how we want to raise our child. So we can see that while the boyfriend's influencing her, also these social norms and reaching this motherhood bar is at the forefront of her mind as well. And so in summary, multiple factors lead young women to initiate the IUD. Method effectiveness, which is commonly emphasized in public health campaigns, is a key factor for young women to decide to get an IUD, but that's not the only factor that women are thinking about. They're thinking about method convenience and the non-contraceptive benefits as well. And so for reproductive justice, there's really evidence that they have a desire to act autonomously, and that's highly developmentally dependent on the adolescent. And also that there's these societal notions of motherhood that really constrain perceived options for timing of parenthood and appropriate context for parenting. And so if we were truly to live in a reproductive justice world, participants and young women wouldn't have to think of the timing of parenthood as delaying other things. So young women would be able to go to school and parent at the same time, would be able to have a career and parent at the same time. However, young women are keenly aware of these societal constraints that it feels like they would have to be delaying something in order to parent their child. And then the other key finding that we found is that adolescents and young adult women really have a range of attitudes towards pregnancy. And so we can really think about attitudes towards pregnancy as a spectrum of attitudes. And so there are some limitations to this study. And so it was a secondary qualitative data analysis. And so the interview guide was not developed for this study question. And so we weren't explicitly asking about young women about their experience with reproductive justice. And also we used insurance status as a proxy for socioeconomic status. And then the sample is participants who already had an IUD placed, and therefore it's biased towards people who are already interested in having an IUD placed. And we also didn't capture those who may have been counseled about having an IUD but ultimately decided not to get an IUD. And so I would like to share some implications, clinical implications from these findings. And so we found that young people require engagement that supports the exercise of autonomy, and they may need additional information to act autonomously. They may need experiential examples to guide decision-making, and that supporting the exercise of autonomy for young people should really consider their developmental stage. And so yes, some adolescents are more developmentally mature than others. However, all of them can be supported in order to develop autonomous decision-making skills when engaging with the healthcare system, and specifically when engaging in reproductive healthcare. And our findings also support existing recommendations for high-quality contraceptive counseling services. So we want to reemphasize that it should be respectful, patient-centered, developmentally tailored, provide options and decision-making support, and also to truly understand the context for individual decision-making. So thank you so much, and I just want to thank my co-authors as well, and specifically our PI, Dr. Elisa Akers. Thank you.
Excellent. Great job, Ava. And Ava earned our highest scoring abstract award for the 2019 Women's Caucus Annual Meeting Program. And so our final speaker will be Kelsey LaBelle.
Okay, can you see the slides?
Yes, we can.
Awesome. All right, hi everybody. Thanks for joining us again today. I'm excited to go through my research with you. My name is Kelsey LaBelle, and I'm a doctoral candidate studying public health at the University of Florida. I'm going to be discussing a research project I recently worked on in conjunction with several of my colleagues at UF. The project sought to understand factors associated with the successful reintegration of sex trafficking survivors from the key informant perspective. I'm going to go over a little background information, and then I'll get into the bulk of the research study. The United States Survivors of Trafficking and Violence Protective Act, TVPA, defines human trafficking as the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for sex or labor. Human trafficking is considered a significant public health problem and human rights issues throughout the world, including here in the United States. Although prevalence is high, it's difficult to establish the exact extent of the crime due to the underground nature of human trafficking and the reluctance of victims to come forward. Estimates suggest human trafficking affects 40 million individuals globally, and it's estimated that approximately 50,000 individuals are victims of human trafficking in the form of labor or sex trafficking each year. It's also the third largest illegal trade commodity and is growing faster than drugs and weapons. The Polaris Project recently released its most up-to-date statistics regarding human trafficking in the US. In 2018, there were 7,859 cases of sex trafficking and 1,249 cases of labor trafficking. There were also 14,749 survivors of sex trafficking and 5,577 survivors of labor trafficking identified. Certain populations of people are more at risk for being trafficked, and some of these risk factors include recent migration or relocation, experiencing physical or sexual abuse in childhood, involvement in the child welfare or juvenile justice system, having incarcerated parents, being runaways, or having mental health or substance abuse disorders. Moreover, poverty appears to be the highest correlated factor to being targeted for trafficking. Human trafficking includes both sex and labor trafficking. For the purposes of this presentation and the research study I was involved in, our focus was just on sex trafficking. Sex trafficking is defined as the recruitment, harboring, transportation, provision, or obtaining of a person for the purpose of a commercial sex act. And a commercial sex act includes any sex act such as prostitution, pornography, or escort services done in exchange for any items of value, such as money, drugs, shelter, food, or clothes. Sex trafficking is a significant public health issue in the US with little understanding of the needs of survivors for successful reintegration into society. Victims experience numerous factors and disparities which impact their desire to accept services and ability to cope with their everyday lives. These include sexual and childhood trauma, coercive control, exploitation of vulnerabilities, and psychological abuse. Sex trafficking is also linked to numerous health concerns. Health consequences include sexually transmitted infections, multiple pregnancies, miscarriages or abortions, undiagnosed chronic disease, injuries or physical assault wounds. And there's also health conditions such as PTSD, anxiety and depression, self-harm, suicidal behaviors, and substance abuse disorders. In recent years, there's been an increased effort to better understand sex trafficking and successful reintegration into society. The present research study was completed as part of a sequence of projects aimed at investigating factors that are pertinent to successful reintegration of sex trafficking survivors. Currently, there's a need for more research on effective interventions for successful recovery of survivors. We lack an understanding of how to effectively help survivors in the recovery process, and limited research exists on evidence-based best practices for professionals working directly with these survivors. This project sought to understand the reintegration process from the perspective of key informants, or people who have been working with sex trafficking survivors. It's a continuation of a previous study that examined factors from the perspective of survivors. And we hoped that by completing this research study, we'd gain a deeper understanding of what can be done to effectively aid survivors in their recovery process. Excuse me. For the methods, key informants were recruited in Palm Beach County, Florida, from human trafficking coalitions, law enforcement, victim service providers, safe houses, domestic violence professionals, mental health professionals, and the Human Trafficking Task Force. To be included in the study, participants had to work directly with sex trafficking survivors, had to have worked for at least 1 year in that field, and had to belong to an organization providing services to human trafficking survivors. Just as a note, the term survivor is used by researchers as a way to further empower individuals who have exited trafficking, as opposed to referring to them as victims. The study was approved by the University of Florida Institutional Review Board, and all interested participants provided informed consent. They were scheduled for a one-time 30 to 60-minute in-person semi-structured interview. Participants were asked questions about the reintegration process, including but not limited to services needed for survivors, proper approaches or skills used by professionals in the field, treatment, prevention, and issues in the field. Recruitment and interviews concluded after content saturation occurred. That is, no new themes or significant topics emerged from additional interviews. To ensure reliability of the data analysis, 2 trained qualitative researchers coded the interviews, and grounded theory methods were used to develop themes from interviews. Peer debriefing from the UF Qualitative Research Colloquium, which is an interdisciplinary data analysis group, was used to confirm categories and themes and enrich data validity overall. I'm going to talk about the findings and discussion and then go into conclusions at the end. So a total of 18 key informants were interviewed and 6 major themes emerged from the data analysis. Both sex trafficking survivors from the previous study and key informants from the current study emphasize themes of rapport, survivor-centered approaches, trauma-informed comprehensive care, and fostering resilience as important factors for successful reintegration of sex trafficking survivors. Key informants also included reducing barriers and lack of operational definitions of success as driving factors that should be included in the overall reintegration process. Despite the role professionals take in the field of human trafficking, the initial focus should be on rapport and relationship building. Rapport is about establishing trust, making survivors feel safe, including survivor-based processes, and reducing shame and guilt they may be experiencing. If the survivor doesn't trust the service provider, no progress can be made. Many people who have come into their survivor's life up until this point have probably exploited them. This makes survivors really wary of establishing new relationships because they feel like everyone they encounter is trying to get something from them. Another important aspect of building rapport is facilitating a sense of safety for the survivors. Survivors are most likely reaching out to professionals because they no longer have safety with their traffickers. So they're looking to professionals provide that new sense of safety. Establishing trust and feelings of safety appear to occur through a survivor-led process. Allowing the survivor to lead the process with key informant support provides a space for them to be empowered in this process. The key informant's responsibility is to be empathetic and non-judgmental in order to reduce the stigma, shame, and guilt among survivors and to help them with this process of reintegration. Key informant interviews also revealed a preference for what is known as a survivor-centered approach. Through a survivor-centered approach, survivor choices are restored and honored. In addition, this approach leads to feelings of empowerment, which can facilitate feelings of self-efficacy, knowing how to ask for help, and becoming their own leader. This approach can also help enhance collaboration between professionals and survivors, which is really important for this process to be successful across the board. A trauma-informed approach considers how survivors respond behaviorally and emotionally to the trauma they have endured. When working with survivors, professionals must take into account how trauma affects survivors during their treatment, and this also applies to the survivor-centered approach. 14 subthemes emerged from the spectrum of comprehensive care and services. Traffickers often meet the most basic needs of their victims, such as housing and food. After exiting their situation, key informants are now responsible for meeting survivor needs so that they do not look elsewhere for support or fall back into human trafficking. All basic needs must be met before starting additional support services to have a better chance at successful recovery. After basic needs are met, substance abuse must be addressed before providing therapeutic services to ensure the effectiveness of these services. It's also recommended to teach healthy coping skills to avoid substance abuse relapse. Many survivors don't have typical life skills and also need to learn basic skills. These skills assist survivors with everyday life so they can become more independent, such as learning how to pay their bills or finding a job. Various therapeutic interventions should be considered part of comprehensive care because they create new coping skills for the survivors. Educational and occupational skills should also be included in a comprehensive care plan. This includes training, employment, entrepreneurial skills, internships, and college opportunities, all of which provide survivors with ways to support themselves long-term. Continuous survivor-led follow-ups while receiving services is important as well, so professionals can check in on survivors and be a supportive network they can rely on. Many survivors don't have family support, therefore knowing that someone cares about them keeps them active in the community and links them to healthier relationships. This ultimately fosters successful reintegration for survivors. An important aspect of fostering resiliency among survivors is changing their views of what happened to them and reinforcing that they were doing what was necessary to survive. A paradigm shift represents a change in the mindset of survivors. Many survivors are emotionally triggered from the trauma they endured. It's important to encourage trauma regulation skills that can help reduce and regulate their trauma. Additionally, a healthy support network is important for resiliency because it fosters relationships that will be healthy and consistent. These could be peer mentoring or community relationships. Appropriate survivor-based peer support can let a successful, stable survivor serve as a role model for the success of another survivor. Developing goals and purpose is another factor of resiliency wherein survivors can give new meaning to their lives. Purpose lets them explore their dreams, and goals shape what they can do to make them come true. Allowing survivors to decide what their goals and purpose may look like is a significant part of fostering resiliency. Operational definitions of success among professionals in the field are not clearly defined, and there's no clear process for measuring success and outcomes for survivors. However, key informants did discuss 4 main themes that can help with defining success for survivors. Determining how to measure success is going to depend almost entirely on the individual, and this will look different for every survivor. Each survivor has unique goals, so it's ideal they take the lead when developing their goals. Key informants in this study supported survivors identifying and taking control of their goals and purpose. Individualized plans of care were deemed necessary as each survivor's situation is unique. Providers can work with survivors to determine what works best for them and then help facilitate a process for them to achieve their chosen goals. It's important to understand that success is a non-linear process and that survivors may experience setbacks as they recover. However, the main goal, as agreed upon by several key informants in these interviews, is not relapsing back into trafficking. The last factor mentioned by key informants was reducing barriers, and they identified several barriers that must be reduced in order for successful reintegration to occur. An important barrier is the lack of self-identification, as many survivors do not know they have been or are currently being trafficked. Additionally, when survivors think they are going to be arrested, they may be reluctant to report. Another barrier is inadequate collaboration and communication between service providers and law enforcement, which hinders efforts to stop trafficking. Despite services available, lack of rapport was identified among key informants. There may be insufficient time or ability to create a relationship with the survivor when they first come into care, causing barriers to services. This can cause survivors to not partake in other services. Another aspect of being trauma-informed is proper self-care among professionals. This was deemed necessary for working in this field to reduce secondary trauma, which may lead to higher rates of burnout. Overall, survivors and key informants emphasize the themes of rapport, survivor-centered approach, trauma-informed comprehensive care, and fostering resilience as factors associated with successful reintegration of sex trafficking survivors. Key informants also identified significant barriers to survivor success and operational definitions of success. It has been difficult for survivors, service providers to determine how to best measure success without agreement on program success. To reduce barriers, it is crucial to improve trust communication and rapport. I think I'm running out of time, so I'm just going to go ahead and go to the conclusions. And if anyone has any questions about limitations, they can ask me. To conclude, the findings from this study have the potential to enhance collaboration efforts of law enforcement and service providers to better assist sex trafficking survivors with their reintegration process. A collaborative approach is absolutely necessary, and increasing collaborative efforts can lead to the creation of a team of partners with complementary expertise to help survivors. Additionally, reducing barriers to successful reintegration can help decrease survivor health disparities while also providing opportunities for reintegration. From a public health perspective, professionals working with sex trafficking survivors should consider these findings to guide community-based practices. Okay, and that's it. So if you have any questions, you can definitely contact me.
Awesome, thank you so much. And Kelsey earned our highest scoring student abstract last year at our annual meeting. So now we'll open the floor to questions, and there was one question in the chat box from Rita, and she was asking Kelsey, what is the racial, ethnic, age breakdown of the survivors? And she wants to see the breakdown because she teaches the subject matter in her women's health issues class.
Okay, so for racial breakdown, I actually don't have that information right in front of me, and I can't remember fully what the racial breakdown was, but I do know that for gender, it was all women, and the ages were across the board, but no one was younger than 18. So I think we had like 18 to 40 something years old who participated in this study.
Okay, excellent, excellent. And we have some extra time for additional questions. So if there is another question, you can unmute yourself and feel free to ask. And also just to let you know that Ava is no longer on the line, so we have Keisha and Kelsey available to answer questions. So I don't see any additional questions in the chat box. And I did want to ask Keisha a question in regards to your use of the psychotherapist. I'm just curious if, you know, the research that you've been doing have led to your need to use the psychotherapist that you mentioned you have available for participants.
Hi, can you hear me?
Yes.
Okay, are you asking if it led to the need for me to use a psychotherapist myself?
No, your participants.
Oh, my participants. Actually, I've already referred, out of the 16 that I've interviewed this month so far, I've already referred 4 over to the therapist. What I found is like during the interviews, when we talk about some of the either work or family or community stressors that are getting to them, that it did lead to like an emotional display. So there have been tears, there have been crying, because they were taking back to moments, or what I found that is sometimes in just having this discussion, they became aware of just how stressed that they've been. And the thing that I didn't want to do is, you know, just come to these women and take the information that I need from them and just leave them open and vulnerable. So I wanted to be able to offer them some type of closure. So the clinician that's on my team has agreed to meet with them, a courtesy visit, you know, for a session, and just make sure that they are taken past that point of triggering. And then if they develop any other need or relationship outside of that, then that's between the therapist and the participant. But I just wanted to make sure I was giving something back to the women who were able to open up and share their stories with me.
Excellent. That was a very thoughtful thing to include with your study. Excellent.
Yes, it was actually discussed with my committee members as well too. So I'm glad that that we were able to make this happen.
All right, perfect. Any additional questions from our attendees? All right, well, I just want to say thank you all. Thank you for our speakers. Thank you for our attendees. And thank you again for watching our first webinar of 2020. If you would like to learn more about the Women's Caucus, please visit our social media sites or visit our website. Thank you.